We're talking about today about failed and failing dentistry, and this is very common. And one of the reasons that you will find this is very common is because people live longer, and people live longer because of the advances in medicine, with oral health, etc. So when we think about it, this will be very common. So patients presenting in your practice, they have a number of issues, number of reasons, which we'll discuss very shortly. And we'll talk about how we treatment plan this patient. This is most of the patients that are present in this webinars are 10 years case study. So far, you'll see some good results, and some not so good results, and some of the decisions that I make, I like to reassess them later on, and hence therefore I change my mind when I treat patients now, because you learn from your past. So what factors would you consider replacing missing teeth and restoring failed dentistry? And I can tell you, people often say, oh, it doesn't fail in my hands. Well, it does fail in my hands, and things go wrong sometimes. But most important is to get a patient's consent to understand. Remember, we discussed earlier about the feasibility of your treatment. When we talk about patients in terms of, I'm trying to go next one, and we talk about complex aesthetics, it is complex aesthetics. I find aesthetics generally very complex because you're not just dealing with asymmetry, or in this case, we call it aesthetic disturbance to the patient, a number of issues we'll talk about the patient. This particular patient was referred to me by Dr. Mehdi Rahimi, and saying, look, really, you need to see Sarkis because there's no need to save those teeth. Some of the teeth need to be removed, and hence we reconnected with this beautiful patient. I had a problem today, and I lost a lot of data, so we're having a data recovery center, so I have to put this whole lecture together within 2 hours. So if there's not as detailed enough, I do apologize, but I think you should be happy with this. And you can see an issue of this patient, simply looking at it. There's uneven gum margins and failing dentistry on posterior segment on the maxilla, gummy smile, all those things. But it does strike you as a concept where you think about, how do we go about this patient? And the complexity of the issue is not simply just saying, oh, well, we're going to do crown here and a crown here, crown here, crown there. That doesn't work that way. And important to understand that people come to you for a reason. And again, we've talked about in this webinar in terms of how do we see things when we're replacing, failed dentistry and failed dentition. So initially, this lovely patient, and I had to ring today to get permission from the patient to be able to use the pictures. She said, you're most welcome. And I'm grateful. And I will tell you about this patient because some of the ladies in the audience would like to see her for their dressmaking. She's one of the best dressmakers for the people in the limelight, in the personalities. So when we talk about the issues as patients present, you think about what would be the most important thing. In other words, what am I thinking? This patient. Is there any other way I can, for instance, look in terms of treatment-wise? What is the patient's main concerns? And as time progresses, you will see in terms of patients' age and how they present themselves and the reason why they let themselves go for so long. Especially when people in the high profile, they meet some people with entertainment business, so they want to know more about how to restore their smile. Sometimes it takes time for a patient to say, look, I need to do something about it. But when that point comes, and people are ready, well, then they're ready. So this is the issue that we need to accept when we're doing this dentistry. And I would like to say that. For instance, in terms of our patient, I'm just trying to find something else here. I apologize. Let's get through. Get this one here. Okay, thank you. So, looking at as a patient overall, and we look at a smile assessment. And you can see, for instance, in this particular case, I like to look at the lips. Don't be so quick to jump in and put the patient in a dental chair, put the mirrors in the patient's mouth, because you want to know your patients. You can see during rest there's slight asymmetry. And the slight asymmetry here, that needs to be qualified naturally. And as the patient smiles, you can see from the patient's point of view, she has a very high gum line. And where there's an issue for the patient or not, it's more or less, we need to understand that it's not an issue for the patient. Well, you have to explain to the patient, what is your main concern? People sometimes can't explain themselves what they really want. So you need to bring the patient in open dialogue conversations to be able to understand where they want to do. I mean, where they want to go. In this particular instance, for instance, the smile line, I find that, you know, you have asymmetry, gum asymmetry, as you go past the laterals. You can see the patient has got a very sort of a high gum line and high lip line, good symmetrical, good thickness of lips. The problem here, if any one of you would like to mention, is that it's not a vertical maxillary excess, you know, VME. If you think it's VME, then rethink, because in many ways, when you look at a patient's profile, you can see that it's not simply VME. And again, it allows me to think, when you look at the gum inflammation around here, there's some other issues that we need to talk about this patient. So when a patient comes in a situation like this, what do we do? Where do we start? How do we think in terms of helping our patients to make the right decisions? In many ways, this is complex, because some of us have a certain way of treating patients, and we say, right, that's how I'm going to treat the patients. I want a formula. And I recall today, my very good colleague Natasha was mentioning, well, you're going to do this, then you're going to do that, and you're going to do that. And I agree. I'm not saying I disagree. But every patient is very unique, and every patient is a different approach. And with experience, you need to understand, how can I approach this patient to be able to have a dialogue, have a communication, in order to help to solve the problem. In this particular occasion, we solved the problem in a particular way, because that was more beneficial for the patient. It was beneficial for timing of treatment, to the budget constraints. And in many ways, we thought, you know, what is the most important thing for this patient? So when we think about how else I like to look at it, I simply don't look at teeth. You see, I like to start in the face. And we look here, do you think, for instance, patients have got reduced occlusion vertical motion? Well, we don't really know. You probably think, obviously, says, well, basically it's reduced because you have increased folding on the face, especially nasolabial fold. You know, she seems to be protrusive. She has a very pronounced mental groove there, labiomental groove. So that's the reason her lips are more or less everted as she closes, but that could be just part of her nature. We don't really know. But what I can tell you from this angle is that she's maxillary more protrusive anterior teeth. And the profile seems to be overclosed. We still can't tell. We still cannot tell. But when you think about it a bit more closely, and you think, well, I'm looking at the smile line, I'm looking at the teeth line, I'm looking at the discrepancy between the anterior four crowns and the posterior teeth, especially canine here. That's an important position. So there's a big step in the gum line here, okay? What would the best treatment for this patient? And so you think in terms of many treatment plans for this patient. You say, is this an adequate, is occlusion vertical mesh adequate? Well, we can't really tell, because that's one point in time we're looking at. There's a number of other things that I have to look at. So it is very common amongst those of my colleagues who had orthodontic treatment to say, oh, it's overclosed straight away. It's not simply overclosed. I need to look at other parameters. Now, I need to understand the most important thing that will determine where occlusion vertical mesh is adequate or not, and we'll discuss that a bit later on. Well, when we think about it, now you can see the retracted views, the sagittal retracted views, and I'm looking at dentition. I can help you in terms of to say that the upper bridgework posterior and the upper left abutments have failed and the bridge is dislodged. Would someone like to comment on those two pictures in terms of to say, is it really overclosed, or why would you consider overclosed, and why would you think about opening up the vertical relation? Can someone make a comment? Isidora, please start.
Well, certainly looks, it appears closed from the anteriors, but when I look at the posterior area, I feel like I could fit some prosthetics there. So it may not very necessarily be closed like you mentioned.
That's right. Well, the most important thing, let's just talk about this. The most important thing is, what we like to say is that I like to sort of assess the individual tooth prognosis. That's the number one thing for me. So I will carry out special tests. And would someone tell me what sort of tests would you carry out to assess the individual tooth prognosis? Anyone, please?
Yeah, I would do the periodontal probing and just check the bone level and just see what's the periodontal status of the tooth. That's number one. Of course, under high magnification, we want to see whether there's any crack or not. And someone who has got a CBCT, they can see much more detail whether there's any hiding crack or not. But I think with the periodontal checkup, we can also see if there's any unusual deepening of the pocket that would say whether there was any crack involved.
That's an excellent way. Just look at that picture. Which tooth would be concerned for you just by looking at it? On the left, on your left, which would be concerned?
Which one I would be concerned?
Mm-hmm.
I would say if that's the 2.5 or 2.4, which one is that?
The one, okay. You're looking, your left side should be the left side of the image, right? For instance. So that should be, you look at 1415, is that what we're looking at? Because that's what I'm looking at, the left image, okay? I mean,
oh, okay. So is that a mirror there? Okay, sorry.
Yeah, that's okay. What would you think as let's just have a quick look at what would be a concern for you. I'll look at the whole thing, okay? This is a hard question. The mesh, it's a hard question.
Yeah, no, that's okay.
But what I like to do is that sometimes I like to say, what am I thinking? Okay, people say, well, sometimes my referring colleagues ask me a question. Well, I can't see what you're seeing. Okay, fine. I understand that because I'm trained, whatever. But the issue is that when I'm looking at a patient, I'm looking with a different eye. And I would immediately say, I see a problem, maybe this one. Something that concerns me here. Okay. And what I would say, just to help you along, because it's a hard question, because you don't know this case, you're just coming, it's not fair. I'm trying to prompt a dialogue here. So I would say, you got no posterior tooth. Is it, you're with me? There's no posterior tooth, right? Yeah. Okay, this patient's a Broxa, just take it from, she's a Broxa. So the loading is actually on the canine, there's a lateral here, right? Can you see that? So I can see this redness here on the gum. So that's a concern for me. You with me or not? Because if there's a crack in there, I don't know. Okay, I don't know. So that's a really concern for me. I'm not concerned about the posterior teeth. I can tell they're filed. Okay, so both sides of posterior teeth are filed. I'll show you later on the images. But the issue is, I'm concerned because if I lose this tooth, that really will change the whole treatment plan.
Yes.
Absolutely.
You agree or not? So,
absolutely. Yeah.
So I'm trying to think of a case. Okay, how am I going to solve this problem? Because these are complex problems. When people tell me, Sarkis, I want the recipe. Where's Natasha? I need a recipe. I can't think. The thing is,
that's me.
I know, gorgeous. I know. You can't have a recipe. Every case is unique. Every case is different with its own complexity.
Hello, Sarkis.
Yes.
This is Sean. I just joined in.
How are you, Sean?
Good, mate. How are you?
Good, good. Any question you have? You want to go back, or are you okay?
No, that's fine. I'll just catch up. So I just joined in when you actually mentioned that redness on the lateral. So what is the patient want on this case?
Well, patient. That's a good question. I'll come back to it later. I'm gonna discuss this case when I come back to it later. That's a good point. We'll come back to it in a minute. That's a good point. Let me answer that question later on the slides, because I need to sort of bring the case and explain the situation before we go to patients, which I agree. I agree. So that is a concern for me immediately, because there's a loading on the anterior dentition. Okay. So, they're saying, oh, well, you have to discuss with the patients regarding all the options of treatment, including no treatment. Well, I agree. But the problem is, there's no treatment is not an option here, is it? Do we agree or we don't agree?
Yeah,
Agree.
100%.
Okay, see, this is the important thing. Because people say you have to discuss there's no treatment, but you can't let this patient go because if you do nothing, it's gonna, the rest of the dentition will fail. It's only a matter of time. So it is your duty of care to explain to the patient exactly what your diagnosis is. I have a patient who says, I don't like your diagnosis. Well, fine. That's my diagnosis. You see what I'm saying? So important fact is that understand where you're coming from. Well, let me ask you another question. If you had to do considerable reconstructive work for this patient, is the occlusion vertical dimension adequate?
Sorry, can you ask the question again, Dr. Sarkis?
If you had to do considerable reconstructive work for this patient, is the occlusion vertical dimension adequate? It does have to do implants here on the lower right and lower left and upper left and upper right. Is it adequate?
By the looks of things, Sarkis, she lost the OVD. Even though the front teeth are crowns, I can see the lower anterior have been worn down, and the posterior teeth have had really bad occlusal.
Right.
It's definitely an OVD problem.
Well, OVD is not a problem, Sean. I'm with you. But see, what I'm talking about is the most important thing is, as I'm assessing this patient, is the amount of restorative space that I need to restore. Is that clear? So I need to know how much restorative space do I need to restore? Like we will consider implants for this patient, okay? So what's the minimum amount of space that we need for an implant crown from a fixture level? Can someone tell me?
At least 12.
12 for a crown?
The critical bone or from the gum?
From the bone. I can't hear it. So there's a chat here. Let me open the chat. Natasha, if there's a chat, let me know. Okay, can you see me? Okay.
There's nothing on the chat.
All right, thank you. So, am I making sense? How long should the implant crown be? So, shortest length of implant crown, roughly. Anybody knows? Okay, let's measure. Okay, let's think. Let's think. The minimal height beneath from the abutment. Okay, how much is the minimum height beneath the abutment? And that actually cemented the crown. Okay, you know you have a direct screw channel to the crown. How thick is that abutment? It's about a millimeter or two. Can be right. Yes.
So the longer the better.
Well, put it this way: you need around about between 5.5 to 6 millimeters to restore. That's minimal. Okay, because you can do it. Now the issue is that that's not enough in terms of what the patient would want. Okay, so we need to determine what we really have to determine for this patient to be able to, decide how much to open the occlusion vertical dimension. No, I can't hear. Sorry. Who's talking? I'm not hearing. I do apologize. I can't hear clearly. Would you be? But look, you can write if you like. Natasha can tell me. If you can write in the chat, if I can't hear you, then Natasha can tell me. But let's just go to the next stage. The question I want to ask is why we have multiple failing to support bridgework also, right? So there's a number of issues we have here. Okay, and is someone trying to make a comment? So we have the occlusion view of the arches, and we have an introver view, frontal and oblique, of these arches. So patient's been functioning on this bridge for a considerable amount of time. Okay, why do you think these restorations fail? I can't hear you, madam. I'm sorry, I can't hear you. If you speak louder or write to me, I'll be most happy to hear you. Okay.
Dr. Christina says loss of posterior vertical.
Okay. All right. Good. Posterior vertical. All right. That's fine. We lost the posterior vertical, but why do we have the question? Why do we have multiple failing to support bridgework?
There's another comment, inadequate force distribution.
Inadequate. If someone's typing and I can't hear it, sorry.
Inadequate force
distribution, yeah.
Inadequate force distribution, where?
Somebody else has written excessive load.
Right, what else?
Those are the only comments we've had till now.
Okay,
I can see there could be high risk of caries there. I would also look at pretty much the diet and the lifestyle factors here as well, because under the bridge.
Perfect. Lifestyle is fantastic.
Okay, nothing's wrong there.
Mm-hmm.
Anything?
What sort of questions do you ask the patient? What would you ask the patient? If you just want to get a roughly what's going on, what would you ask the patient?
What are your main concerns?
Say again?
What are your main concerns? Do you have any aesthetic concerns? Do you have any functional concerns?
You've got the concerns. Let me give an example. The main concerns are, I'll come to it in a minute. I want to give that later on. Okay, I'll come because I want to build up a case here. What would you ask the patient? I mean, that's the question is, what has failed here?
I guess you'd ask, what's the history? What happened?
Well, what's failed here? Tell me.
Dr. Sarkis, Khan Ravi has asked, why did she lose so many teeth? Do we have a history on that?
That's right. The history of tooth loss. That's number one. Why did you lose your teeth? Okay. Well, let me give you an answer for that. She's from overseas, from Iran, and where they have a lot of high sugar diet as a child. So mainly for caries, periodontal factors are quite within normal limits. My oral health therapist, Christy, she's measured them as at some pocketing up to about 4.
Actually watching tonight.
Oh, fabulous. Maybe 4, maximum 5. So she will undergo periodontal therapy naturally. So what would you do for this patient? I mean, another question to ask the patient, what's really failing here? Is it the teeth or the restorations?
Restorations.
Restorations are failing. Why are they failing? Someone says lack of canine guidance, paraprofessional habits, bruxism. Okay. Beverly, thank you for those. Sonali, Prabhu, thank you. I really enjoy all these comments. I really enjoy that. When would we, because, okay, canine guidance, understand, but is canine guidance responsible for failure of what you see? Is learning responsible for failure of what you see?
Prof, may I comment what it would be more of? May I comment what it would be more of orthodontic background more than restorative? I think this patient is closed, low vertical dimension, 100% deep bite. So I think it's the teeth that is failing, and whatever you do, whatever good work has been done, I think they will fail because of that. So I think we establish a better occlusion first before we start anything.
So you think occlusion has got something to do with failing of the restorations and teeth, is that correct?
Definitely. So yeah, the high caries risk, all this is considered the risks, but I think it's the grinding with the 100% deep bite is part of the problem as well.
Mm-hmm. Well, okay, I will maintain your comments there, and I thank you for the comment. Let me ask another question. I see Okay, I see a lot of patients have major reconstructive work done.
Dr.
And
Sarkis,
yeah.
Reed Said has asked, Siad Said has asked, periodontal disease aggravated with traumatic occlusion anteriorly?
No, periodontal disease doesn't activate traumatic
Okay.
occlusion. Periodontal disease can cause secondary trauma.
No,
Okay.
I think he's talking about secondary occlusal trauma.
Yeah,
Okay.
secondary closure trauma, but we don't have a periodontal disease here.
Okay. Okay.
It's a mild periodontal disease, it's under control. I'll give you that data already. But why would these restorations fail? Dr. Ahmed mentioned about occlusion. Okay, that's fine. But the patient's been functioning for a long time. This bridge has been in situ for about 20 years. Why can they fail? If you look on the left side, you can see there's been a number of repairs, gum recessions. Well, there's gum recessions around the posterior restorations, and there's no gum recession. Well, there are gum recessions and anterior restorations. Why is that?
Maybe lifestyle changes. Sonali Prabhu's mentioned about lifestyle changes.
You'll see there with traumatic anteriorly, lifestyle changes. Okay. All right. You see, one of the important things that we need to think about is that when we try to restore dentition, is we need to have a endpoint position when we restoring teeth and mouth. And this we plan very, very carefully. It doesn't happen automatically. That's the problem, you see. And so this treatment was done by two separate dentists. One restored posterior teeth, and then later in life, she got the anterior teeth done. The trouble being is the anterior, most of the restorations, the marginal design is poor. The restored design is poor. And occlusion is part of the restored design. It's not just a one component. So there's a poor margin integrity. There's poor resistance and retention. There's poor integration of the prosthesis within the stomatognostic system, that is the masticatory system. So if on top of that, the poor dentistry has resulted in a number of factors, and occlusion is one of them, where there's unnecessary loading, there's inadequate resistance retention, there's uncementation of the retainers, and the whole thing starts to fail. And because it fails, it's like a cascading effect, you see. And the problem is that you cannot just say you have to do orthodontics, you have to get the occlusion right, which is part of it. And I agree with Dr. Ahmed. But also the fact that the whole restorative design has not been conducted correctly. I see a lot of patients from my very good mentors who've taught me, who have treated these patients over 35, 40 years, and I have retired. I see their patients now referred to me by these colleagues of mine, and patients have bruxism, but although the restorations have worn and chipped, but the integrity of the system has maintained very, very well. So because design was correctly done and occlusal prescription was correctly done, when you brux, everything's out the door, I can assure you, okay? You have to understand how to redistribute load, and I accept that. But the important part is that how you design your restorations and your margins and how to get good core integrity is the key. And most of those important critical factors has been basically ignored in this patient, unfortunately. So that's one of the reasons we have lots of failure restorations. But the question is, how do I fix the problem? The question is, how do I fix this to give the patient long-term predictability? Sometimes we, all dentists, want to sell cases to the patient. And the patients buy because you promised them to have a beautiful smile. You promised them the world just to sell the case. And remember, in my lectures in the college, we teach you, we don't sell dentistry. We are doctors. We present dentistry. We help our patients to achieve optimal comfort, function, and aesthetics. And that's how we think. That's how I think, at least. And that's how I have all my colleagues, all my students who are in the college learn the concept. So when we talk about the next stage for this patient, okay, we look at a history of missing and multiple failed support restorations. The first thing I did for this.
Got a question.
Yes.
It says, when you say margin design is not good, can you please expand on that?
I will. I will come back to that. So let me go back to the system. The marginal design of your restoration depends. Before you start your restoration, you have to decide what type of restorations you're going to institute in your treatment. In other words, are you going to use metal ceramic, or you're going to use glass-based ceramic, or you're going to use crystalline polycrystalline ceramic, which is a zirconia, for instance. So that will determine your marginal design. Okay. Now then you have to determine what type of fit do you want. You understand? So in other words, zirconia and glass ceramics, which is a Emax, for instance, they have different marginal integrities than metal ceramics would be. Okay. And you're looking at where do you place your margins. In other words, if you have a very high static zone, what type of material would you use in that high static zone? So the marginal design is very important, is where you place your margin. That also depends on the amount of core integrity, okay? Amount of resistance rotation that your preparation has is all part of the whole thing. So it's one thing, not just one, just breaking down different areas. So marginal design will tell you where a crown will stop at the tooth crown junction in the head, okay? Where in the head of the patient. That's exactly where you're going to be. So it's not as simple as saying, I'm going to cap this, I can make better crown because I'm going to tell them, no, it's not that simple. And I'll tell you why. Let's go. Good question. Please maintain that question. Ask me again. So I'm just going to see the chat room. Middle is appropriate based on central relation, restore posterior staples, then anteriors. Renata, okay, to everyone. Well, thank you. Thank you for that, Renata. You know, this is a prescription you have, right? And I'll tell you why I will do it differently. And there's a number of ways to treat. As long as there's one diagnosis or another, there's many ways to treat it. And I agree with you, of course. But when you look at this case, let me assure you that we have adequate room for placing implants on all segments that you wish to do. And you can see there's an image of a provisional bridgework in place on both sides of this patient. And there's some provisional crowns have been placed. And we remove the residual teeth to allow bone regeneration and while maintaining patient comfort. So I've given you a couple of dimensions which will help you to assess exactly that there's an adequate bone for this patient. Now moving on, I'm just trying to get this next one going. Okay, now when we look at initial presentation, then let's look at the patient factors. Now, there was a question who said, Sean, I think you mentioned that first. What does the patient want? Well, can someone mention to me what the patient wishes to have? So you have enough information for this patient. What would the patient ask? Sean, you go ahead.
Yeah, so the question is that what are the patient wishes? Are they realistic expectations? Does she look for Hollywood smile, or does she want to improve on the looks of it? Because she got a gummy smile, all those crown and bridge work look really hideous, popping like a rabbit. That's just my opinion. But we want to know what she sees when she looks in the mirror.
Okay. Let me ask you another question. A patient is about 50, I think 50 years old there, 50, 55 years old there. And she's been like this for a long time, hasn't she? And because the upper left bridgework failed, it dropped. It was a situation she just doesn't want to have any full dentures, doesn't want any dentures. She wants to have something fixed, and she realizes that time has come. But something that's important that has prompted her to come for treatment is a grandchild. The grandchild said, Grandma, you don't look quite right. Okay, I'm not sure the comment, I can't remember, but that really changed it. Says grandchildren are very honest. Sometimes they speak the truth. And And there she is presenting in this situation. And when you think about this, there's a big connection between grandmas and grandchildren. And when that happens, they will listen more to the grandchildren because they have an honest view. And she won't ever improve the smile. She won't ever be able to chew. And she's been a number of dentists who have suggested different treatments. For instance, one of the treatment was to remove upper and lower teeth and have all on 6, all on 4 on top, and all on 4 on the bottom. And she didn't like that idea, and then was referred back to my practice. Basically, her wishes are to smile, to be able to chew, have a comfort, and want to fix restoration. We tend to think what's right for this patient from our point of view, but we need to sort of maintain this patient's biopsychosocial well-being, which means be able to help them in making the right decision for themselves. And that's very crucial from the treatment point of view. When you think about it, the patient's concern, as I said, was she's a very confident woman, deals with people in the entertainment industry all the time, but for some reason she sees a lot of beautiful teeth and beautiful smiles come in, and she sort of mentioned to me that look, I've seen your work, and I really want to have a nice smile, but I don't think you can create a beautiful smile like you've done for others. And that's sometimes people feel that way.
Asked a question, Dr. Sarkis. Baraya Ahmed, I just want to ensure I have roughly got the process right. Would greatly appreciate if you could please critique the following to start such a case.
She said you take the facial records to establish centric
okay.
alignment, measure OVD, take a bite reg and make study models, then use this info to articulate the models on a semi-adjustable articulator. Do a wax up, take a putty key impression of that, create temporaries, and then do a try-in. Adjust the incisal edge position, 2 millimeters should be visible at rest, and go from there.
I don't have to do that because that's what we talk about when we're doing case discussion and the case. I mean, this is about discussing the patient's case. I would go for that. I mean, you're looking at a recipe, okay? And there's many ways of doing that. There's just one way of doing it that particular way. I mean, naturally, all the patients are placed on the articulator and assessed. But even before we place on the articulator, we have to look after perio, endo, caries control, overall gum and bone health, temporize. Well, before the temporize, you can mount it the articulator because then you have a right position. And naturally, we like to maintain the existing bridgework to be able to get the initial vertical animation. Then we can open up if we need to. But I don't need to open up, it's on the articulator, the diagnostic wax up, because there's other ways of doing it. Yeah, and I appreciate your lovely comment. That's one recipe where I like to put things on articulator and have a look at it. But the best articulator I can show is the mouth. And I'll discuss that a bit further. So when we look at this particular patient, to me, it's more important to look at what the patient's coming from, and the rest of the semantics and the other treatment can be done later. But I like to talk about the specific risk factors for the maxilla. Articulate is a great idea, and I accept that. It's wonderful. It's a recipe while we're doing it. We do mount this on the articulate. Of course we do. That's not a part of it. But there's some important factors to assess for this patient. And the specific risk factors for this particular patient is that does she have unrealistic demands? I think most people have. Okay, and our small lines height is not a vertical maxillary excess, and lip symmetry. It's symmetrical lip. That's a great bonus for this case. Okay, you can't see the symmetry on the articulator, I'm afraid. You got to see this in the mouth directly when you visualize it. Articulator will come later on in the treatment. And again, gum asymmetry. There's the general gum asymmetry. You can see that when you're coming across the canals, it drops. Okay, in many ways, this is not a vertical maxillary excess. Patient on class 2, DIF2, with an underdeveloped premaxilla. That's what the case is. And you have to think about which way you want to go ahead with this case before you even do diagnostic work. And the facial development, she's brachycephalic, all right, which is a short face. And again, biotype, thick, moderate, asymmetrical. And when you look at the bone loss, horizontal bone loss, I feel the teeth, the anterior 4 teeth are highly compromised. canine seems fine. Okay, and again, posterior segment we have poor prognosis, and naturally bone volume. Well, bone volume is not too bad. So these are important considerations I need to do. Okay, and look at then occlusional factors. Okay, I will make all these considerations in my mind, and following this, we can either scan or we can take impressions and pour them and mount them, and use the opportunity for this patient to be able to restore their mouth and temporize them. But these are very important factors to consider, okay, before I will go ahead and do any other treatment for this patient. So I will discuss this whole factors with the patient, explain the situation, and then patient is ready to take the next step. And then I will take all the necessary diagnostic records, such as articulator mounting. In this case, I'll probably do face bone mounting, which is an important part of the treatment process. Now, the question was, would you consider, all on 6 or all on 4? I mean, which two would you say? Which two are important to save? Okay. And how can we improve the prognosis of the compromised teeth? You see, to me, these are very important factors before I consider any diagnostic workup, because what's the use of doing all this when you have all the other issues to consider? And that's very important to understand before we commit the patient further. So naturally, probing or hide instructions, careless control, maintain where you can, but sometimes it can be maintained, so you make a decision for the patient. And that's part of the whole treatment process. So I need to be able to improve the prognosis of teeth. So the problem that I see, is that patients got a tendency to have a maxillary protrusion and canted. It's like a high pitch, like negative pitch, but high smile line. And the angle of the maxilla is very, very high. In other words, if you have to do a static dentistry for this patient, imagine if someone decided to take all the upper teeth out and do all on 4. This would be almost an impossible case to treat. It would be aesthetic nightmare, disaster, because the position of the upper lip, you have to do so much osteotomy, and then you can never produce the position of the teeth, in this case, to support the higher lip line. And that's critical in these cases. Therefore, as I mentioned earlier on, when we look at tooth number 1, 2, that starts to worry me, maybe a fracture there. So this is the reason why I would be hesitant in investigating this important area. Make sure there's no crack in there, do my testing, adjust the occlusion in the mouth, okay, reduce any anterior guidance and any contact that's heavy contact on 1, 2, check for fremitus, and my oral therapist is highly trained area. She can check for everything else. I will adjust this immediately to prevent further disaster while we're treating the patient, not treatment process. So that'll be the number 1 thing before I even do anything else. So having said that, okay, the way I see it, in this particular case, with this particular patient, you can see that, if I can make this work. So what am I thinking? Okay, I'm thinking as I'm restoring this patient, what would be the end tooth position? How do I design the final restorations? And what would be my occlusion prescription? Okay, I don't need an articulator to tell me that, because I can see in the mouth exactly where it's going to go. So if I have to open up the bite, what will happen if you open up the bite for this patient? Okay, with a class 2 and D2, what happens to the patient's chin? It's going to disappear. So before I would open the bite, I would consider what would be the consequences of doing this. See, everything we do in dentistry has a consequence. Unfortunately, when you place it on the articulator, you can't see the facial pattern. Okay, it's difficult to see that. Now, plastic surgeons have got a software they can manipulate. That's even very difficult to assess. So we have to think of the soft tissues that are surrounding, draping the hard tissues. So if you decide to mount the articulators, you have to see how much of the chin deviation do you have and how much you might exaggerate the anterior overbite and overjet. I can deal with the overbite, but there's no overjet issues. Then there's when you open the bite, for instance, in a class 2 patient, what's really happening is you lose your anterior coupling. And if you lose your anterior coupling, how are you going to deal with that? especially canine guidance, which you want to establish. Okay, where would your guidance be when you have to lose the upper premolars, for instance? Okay, how would you define your occlusion? How you present your, how do you design your occlusion prescription? So all these are very important considerations. Okay, therefore, it's not as simple as looking at mechanical solution as much as looking at how can I design restorations to get the best aesthetic and functional outcome for this particular patient. So that's exactly what I'm thinking, without taking any further records, just looking at the images, okay, and knowing which way to go. In this particular case, I'll have my oral therapist, Christy, to come in, and I will design, she will go to periodontal charting and treatment, give me a scenario where the support system is. In more complex cases, I will engage your periodontal colleagues of mine to be able to see how do we look at this case. So when we think about these cases, okay, understand that first thing we do is to stabilize and control the disease process. That's number one. Then you reassess. Okay, you can take initial diagnostic models. There's a diagnostic phase. Okay, that's when I will consider my mounting. If I need diagnostic mock-up, I can do it in the mouth and build up later on. There's many ways doing it. I will reassess how the patient's functioning, and then I will plan my definite restorations, and then I will go ahead and do my maintenance. The maintenance issue starts from the initial stabilization phase. I'm listening. Go ahead. Yes, I'm listening. So there was a comment.
I think that was some background noise.
Yeah, background noise, I guess.
Okay, thank you.
Dr. Sakis, Khan Ravi has asked, should we consider intruding the upper anterior teeth?
That's a very good question. I just want to go to the previous slide. Okay. Okay, so let's say we intrude the upper teeth, and I'm with you. Remember, we have teeth with multiple infections on posterior segments, bilaterally, upper bilateral teeth. Those are fine. Now, if you had to intrude the upper teeth, and at the time we didn't have clear aligner technology that were developed. You only have upper canines and upper right one, the molars is poor prognosis. So I would presume you would, maintain all the teeth with some temporaries, even though they have poor prognosis posteriorly. So you have clear aligners, you would move her up, correct? That would be your, because there's an anchorage issue here, right? Is everyone on orthodontics? You have an anchorage issues, right, Robbie, when you want to lift it up? You need some sort of an anchorage to be able to intrude teeth. The problem is that, or if you do orthodontics. Now, here's the issue. That's a really good question. I want to address it a different way. Let me just go back. The problem is, if there's orthodontists in the room, please confirm. The problem is that she has a high-angled maxillary alveolar process. When you want to intrude teeth with a high-angled maxillary anterior process, it's almost impossible. If the maxilla was up and down, you could easily intrude teeth. So in other words, the maxilla this way, you could intrude. It's that way, which way your first go. That way it's almost difficult. You actually end up pushing them out, okay? So intrusion in this case will be very, very difficult, okay? I think, Christina Howard, are you there? No? Okay. Raise hand. You raise your hand. Can you say a few words, or you can't, or you agree or disagree?
Dr. Christina has asked a question. How would you like to do it? I think she's referring to Ravi's question, I guess.
Well, I think intruding this tip will be difficult. Okay, that's number one. Number two, the question I have to ask the patient is that at what stage in your life are you? Would you like to have an orthodontic treatment? And in many ways, if you explain well, they can. But for me, I think we can have a restorative solution better for this patient than orthodontic, because I cannot guarantee that orthodontic solution will work with the minimal anchorage problem that we have. We have a really minimal anchorage, and we need anchorage. Now, this is 10-year case, okay? TADs and all those things weren't developed. I guess using TADs, you might be able to get away with it. That's a lot of work for something that was almost like a millimeter or two. So I think the concept is very noble, but from practical point of view, that would be difficult. Isidora, what do you think?
Yeah, the intrusion would be very complicated.
Yeah.
It's
It's
a
a
good
novel idea. It's a novel idea.
The idea is to obviously remove the gummy smile.
Yeah.
But I guess we could also look at crown lengthening to achieve that as well.
Yes, especially you have to read those crowns, right?
Yes.
And one more thing, that you have plenty of attached gingiva here, Mike. Plenty. You've got plenty of attached gingiva.
Dr. Sarkis, Dr. Mohammed Solomon Sohail Menon writes, instead of intruding, crown lengthening would have been an option unless patient is happy to lose gummy smile.
Well, good question. That's probably the intention, and that was discussed with the patient. Okay, let's just go to the next one. Yeah, next one. Okay, so we went here, Okay, so what I would normally do in this particular case is that we got plenty of attached gingiva, and you know the dimensions of the teeth. This is maxilla that's underdeveloped, and there's an adequate root length. The roots are nice and broad and also tapering. Because I lost my lecture material, I couldn't get the sagittal images, but I can assure roots are not tapering. They are nice and thick, bulky roots. And in this particular instance, I see with the diagnostic mock-up for this patient to determine the length of the teeth you want to display. And naturally, because she's class 2B2, the crowns are longer. So we need to actually shift this frame from here, it's further up. And the only way to do that is to basically issue a diagnostic mock-up. I put a little black texture here, so it tells you exactly how much teeth you're showing. And then you measure by reducing the teeth. So I'll reduce some of the teeth, and then you know how much gum recontouring you need to do. So I use, for instance, an NTI burr. Please don't try this if you haven't done this. We teach this at the college. This is part of the important armamentarium that we teach at the college, how to do this properly. And you go through a course when we do the perioplastic, something in module 6. And once we do this, we create, optimal anatomy as we want to, because the teeth may appear long. That's fine, but I'm not really worried about it. The most important thing, what I'm thinking in this case, is that we have adequate attached gingiva. We have more than about 8 millimeters of attached gingiva, so there's plenty of room to carve the teeth. You can see there's minimal bleeding. This is done in one visit, but the whole thing is done in one visit in this case. So I'll be doing the gum recontouring, the provisional restorations, the extractions, all done in one visit.
Dr. Sarkis, is that a ceramic burr, the burr that you've used? Somebody has asked a question.
It's a special ceramic burr, yes. Okay. And before you do this, you need to be trained. So that's what we do at the college. We train you. So don't attempt without knowing how to do this properly, please. I'm happy to teach, but don't just go ahead and do this. The beauty of this is you have almost like a bloodless field. Okay, it's easy to do, and you maintain your proper gingival outline. Okay, to your progression. Like centrals are about similar height as canines. Okay, and maybe it's like similar, while the laterals are slightly low. So normal things that you would normally do in your denture setup, for instance. And following this, we go ahead and we remove the crowns with sectional. And now question is, before all this treatment, what did you promise to the patient? You said, I'm going to really give you a beautiful smile. Was that the promise you made? How did you go about it? What did you promise to the patient? You have your models now at the stage on the articulator. You've done your diagnostic mock-up. You got your template that you're going to have your pull down to make your temporaries. What did you really promise to your patient? Did you say that I'm going to give you beautiful crowns and it's all really perfect? Did you say that to the patient? Okay. You see, it's not about recipe. That's what I'm trying to make you think as colleagues. If you think like a recipe, then you're totally out of whack. You're not in line. You said to the patient, look, I'm not really sure about these restorations. When I remove these restorations, I'll be in a better position to assess what I find inside. Now, remove these crowns. You don't go to these crowns and you get the hammer, like a crown remover, you tap, tap, tap off. You're going to cause more damage. These front teeth are the most critical things for me to keep. If I lose one tooth, it will change the treatment plan drastically. Okay, so removing these crowns and I think today Vivek was with me. He could see how carefully I removed them. There's special techniques, and do not use the hammer. There's other ways of doing it. So think about when you remove a crown, how to preserve the teeth. Because that if there was a crack later on under your crown, I can assure you, you caused it because you did remove this crown in a very gentle manner. So we prepped them, and we found lots of goodies. Okay, lots of goodies. You can see when we talk about poor marginal design, okay, you can see that all the leakage that's present, all have been there for a while. But you know, if you leave it longer, patient will eventually end up losing all their teeth. So from here, we will go ahead and refine our margins, okay, as per our gum line. It's not a final margin. This is not a definite margin. We're going to make temporaries. We've got things to do. We got to do implants. We got to plan the implants posteriorly. We got a lot of other things to do. But at the same time, we're getting a smile line set up, getting all the other parameters set up. Is everyone on the same wavelength as me up to this stage? If you're not, please tell me so I can explain. Anyone, any questions? I'm happy to explain.
It's making a lot of sense. Thank you very much.
Oh, good. Excellent. Excellent. So then we go ahead and we prepare his teeth to the level, because you can see that even in this particular situation, there's not a lot of bleeding. In many ways, I don't like the fact that people raise flaps to do crown lengthening procedure. It can be done very simply because you have to wait about good 6 months for that. But in this particular case, I can wait up to about 6 weeks and have my margins all stabilized. So here, I will go ahead and you can see the amount of room that's available. We have patients with severe bruxa. I can choose to open a bite. You probably did in this particular case because I want to also restore the posterior teeth. And we have your template from your diagnostic wax up and articular mounting. I haven't put those pictures because I think, you know, this is about discussion. And once we have done that, then you make your temporaries and you issue them, and you allow the gums to heal. Temporaries, you can see that loss of support, loss of tissues on the right side because of complicating bridgework. Then you go back in, take this out, you refill that area and allow the patient to heal. You improve lip support. The patient was able to function without any posterior left quadrant, but there's enough on the upper right quadrant. And I also maintained the last tooth on the upper arch to give me the abutment for provisional. So from here, then we proceed with implant placement. Naturally, we go to molar occlusion. Implants are placed. I mean, this is a slam dunk dentistry. Yes, question?
Dr. Sarkis, someone's asked, I'm amazed that there is minimal bleeding post-op gingivectomy using a burr. What is the secret to bleeding control after cutting so much gingiva away?
Let me ask you, who's the question? Let me answer, who's the question?
It's coming from, just give me a minute. Scroll up.
Josh, fantastic question.
Yeah.
Can I ask you a
yeah.
question? Josh, could you come on board and tell me why do you think
Josh, yeah.
Tell me what do you think is the case? I'll just go up. Sorry, I'm going to go up. What do you think is the case? It's always the same case. What do you think is the case? That's a very good observation. Are you there, Josh? You can write if you wish. Can someone else answer me?
Yeah, he's here, but I think he's ready to type or...
Okay, I'm here. I'd love to listen. Please proceed.
Just waiting for him to type, or probably Josh, you can just...
May I give it a go?
Yes, lovely.
Yeah, go ahead.
Is that because of the action of the bear, which might burn the small capillaries?
It's right. It's a cauterizing effect. Absolutely. It's a cauterizing effect. Okay. And
thank you, Dr. Sarkis.
My pleasure. Very well said. Very well said. It's a cauterizing effect. There's a technique of doing it. And we run courses on this, but part of the, when you do the college, I think it's module 8, personal and tissue management. We go right through this. You become an expert in this area. And the implants are placed. And they're all part of the training process. People tell me, you know what, can I just come and do module number 4? No, you can't. You have to do the whole thing. Because the question you're going to ask me are related to each other. That's what the module's down. 1, 2, 3. Like 1 and 2 are the most important part of it. Okay? Because I'll be asking you to give me a good images. Because an image will tell me what you're thinking. Image will tell me what you're seeing. Image will tell me your thinking, your eyes. See what the eye cannot see, the mind cannot recognize. And it's very, very important. So correct images will tell me what you're thinking. So it's very important that you learn photography. You learn how to take good intraoral, the labial and facial images. It's very important to understand. Okay, and I'll be teaching you that because I'm the clinician. Every image you see, even on my brochure that we send you, it's all my work. I've taken those pictures, except the front cover and the back cover. Okay, but they're all patients. Front cover is all the academy. So the important part of it is that as you take images, you diagnose. You see, and you diagnose because you see, your eyes see what your eyes see. The camera points at that. See, in many ways, when I was marking papers for other colleges, like King's College, a guy from Congo used to send with a macro lens on his iPhone his cases, and actually marking better marks than the hotshot guy from Beverly Hills who used to have the best SLR camera because he knew exactly what he was talking about. He knew exactly what he was seeing. So that's really important. So they'll help you with your camera, show how you choose camera, but we're going to teach you what to see. And that's very important from a diagnostic point of view. It's what you're seeing is two different things. And how you put your camera to see that, that's also very, very important. I mean, I love seeing some of the images that my colleagues present, but it's very important to understand what you're seeing. For instance, in this particular case, after gum maturation, we did another preparation, refining preparations before we take impressions, okay? Again, minimal bleeding, good margins, okay? Good margins, good core integrity. We maintain the core of this teeth. That's very, very important, okay? And then we're ready to take full implant level and tooth level impressions. This is impressions we take for this particular patient, and there's a special technique of doing this in one go. A number of ways of doing it. We'll teach you that. We'll tell you how to take full arch impressions. And there's not a lot of tricks, but good thinking here to do. In the minimal bleeding, enough room for the blood body to penetrate and create good tear strength that you can then have your margins replicated by your technician, and how to give those important instructions to technicians so they know what they're doing. So I'm very pedantic for my cases. I'm very pedantic for my patients. You can see I maintain the tooth on the upper left side. We did lose an implant. We lost, I think, the middle one here. We lost the middle one implant here. I remember this case. But again, that's one of the reasons sometimes you place 3 implants, because in this particular case, I wasn't too sure about the bone softness, the density of the bone, and so I said, I'm not quite sure about this, but nevertheless, 2 ways adequate to restore this patient. The impressions are taken at the implant level. Both arches, upper and lower, were placed all at the same time. We're going to go through some of the x-rays. There's 2011, and again, temporary bridgework, provisional bridgework is in situ. In this particular time, we use a provisional bridgework to increase the occlusion vertical dimension to an ideal smile line, as ideal maxillary plane, and that's determined clinically, not by the articulator, because that gives you a more realistic picture. And that's very important to understand. Articulator is one thing, and that's a very good comment that was made earlier. Very good, but doesn't tell you much information. And once I'm really, really happy with the provisional stage, then this will be transferred on the articulator and then further copied by and improved on the restored design when we construct the definitive restorations in the upper and lower arches of this patient. Now, I haven't replaced the existing crowns on 3.4 and 3.5. We decided to leave the lower arch for the time being because of financial constraints, but nevertheless, we can give her a functional occlusion, which is eventually becomes a habitual occlusion, which is a therapeutic occlusion. And again, this is you can see that I restore the maxilla first, because that establishes my occlusal plane. in a lot of dental schools, they're taught to restore the mandibular plane first. I disagree with that because I decide where the smile line is and then decide which way the mandibular plane will go. It's more accurate, and aesthetics is an important part of the driving the restorative outcome. And that's how I like to look at it. So, you know, from 11, went back, this is 2015, and you can see I maintain the posterior tooth. Although I had a poor prognosis, we could always remove that tooth and section the posterior crown from it. That's always an option, but it's very well, it's held very well. The bone levels and the attachments are very good. My oral health therapist, Christy, checks them, and she's very happy with them. You can see the bone levels are maintained. Lost a little bone level on the lower left 6 area. You think there's a bit of opening, there's no opening. It's basically, that's the X-ray pattern. Angle the OPG. This is, I think, last year we've taken. So overall, the beauty is that patients who really brucks come with a great bone. They have great bone, no problems. I've never seen a patient with a, if you're a patient with a bruxism with a periodontal disease, it's an absolute disaster. But thank God most of the bruxers do have good bone volume that we can see. And naturally, we want to see the prosthetic part of it. One important thing is that oral hygiene is very important, how to maintain oral hygiene. Now you're going to say, probably Sarkis, you did a zirconia crown. You keep talking against it, so why did you do the zirconia crown? Can someone ask me that question, please? Come on, ask me the question.
Why did you do zirconia crown?
I thought they were asked. Well, it's an interesting question. I'm going to answer you. I thought at the time, I really enjoyed the fully contoured zirconia. All the zirconia crowns are fully contoured right to the labial edge, and then it's cut back and then Emax type of porcelain added to it. So it's like a layered porcelain that gives you that nice natural effect. And there's no reason why we could have done this with, you know, metal ceramic crowns. So I mainly did zirconia crowns because I had the posterior bridgework to match with. And that was my aim. But I'll show you later on what happens with a lot of zirconia crowns because they are very hard. They don't have much of a give. That's a problem I have with even with special bruxing patients. And you can see that we lost one of the implants here. That's a reverse that one, unfortunately. The picture's reversed. And implants are planned accordingly to be able to place in the right place. Okay. And here's the zirconia crowns, all adjusted, good canine stops, good posterior contacts for this particular patient. You can see the tuberous implant here is quite big. That's very normal. I'm very happy with the initial outcome. Here's the result. This is initial cementation that was removed. That's why there's a slight redness there. So I think, you know, there's a good aesthetic integration looking through orally. We could have grafted on the bilaterally. Okay, we could have done that. That's something that I would have considered. Now we consider grafting there as well. But at the time, the patients don't know, for some reason that would, when I look back in retrospectively, I would have considered that grafting that area myself. And this is before and this is after intraorally. You know, adjust your occlusion, looking at good margins. Imagine you have to take the whole tooth out and place a fully supporting implant bridgework. How difficult it will be to reproduce this part of the bone, and what happens if implants fail in due course. So in many ways, these are smile line. And you thought that we reduced the gummy smile. Well, we tried, but the more you know, improved smile the patient has, the more they will raise their lip. Always make sure when you deal with your patients, ask them fully smile. They say, I don't smile this way. I says, yes, you do. Come on, lift it up. And you can see another tubular wisdom in most of the patients. Because that's what they see. When you place your restorations, the lips immediately go up. So you got to make sure you get it right. And I explain them what I do. So this is a profile view of the same patient. And we have a good lip drape in our outcome. And you can see a full smile line again, quite high. Okay, we could improve prosthetics here so that there's not an issue for the patient, but at the time, I thought we could have done a bit more balloon prosthetics. We can still do it. You can unscrew and you can see how we've changed the patient's whole outcome and how creating that nice aesthetic effect and lifting the high pitch maxilla right up and improving the smile line. And did we really open an occlusion vertical dimension? Perhaps a little bit, maybe 2 millimeters anterior, and that still maintain good cheat profile. Overall, I think we have improved the patient's confidence in this particular case. And dentistry does really change people's lives. Now, this case is now almost 10 years, I believe. And you can see how it all changes, different angles, different views, more confident patients. And we're going back again. We talk about the education. And you have to understand that we need to plan for results and not for procedures. I keep saying that. I could show you traditional prosthodontics where we do all the things in a formatted way. That's fine. That works. But there are other confounding factors, okay, that are important to see. Now, there's a few more slides to show you. And all these cases that you see, we go into far more detail in the college program, which is about to start soon. And the important part of this college program is to be able to help you to produce your own style and to think like a specialist and to practice like a specialist. In other words, you will develop your unique style, just like if you're a musician, you have piano, you play violin, or you dance. You so develop your own unique style that's unique to you. And you learn how to critically appraise papers, understand how to treat the patients, how to talk to the patients. When we discuss a patient interview process, as some of our referring colleagues have been inside with their referring patients, it's a totally different concept because no one's really taught you how to talk to the patients, how to interview the patient, how to use the correct language to get the best information from the patient, which will help you in your diagnosis and treatment planning. Because most of the time, patients are telling the full story, and you need to know that. That's very, very important. We have a short course coming up, one-day course coming up on problem solving on composite technology, and particular patients who've seen the videos on this. I think the link will be sent to you if you ever seen it. I did last time. And how do you treat those patients in emergency aesthetics? How do you use fiber resin composite bridges? How to construct them? How do you get the patient from A to B in the shortest possible time and give them predictability? That's really important. I think this should be an important part of the general practice that you can use every day, whether you're doing implants, you're doing general dentistry. You can get these patients walking on the streets every day. Every day, they're in need for dentistry, except they're being quoted on somebody like it's going to cost you 50 grand. With a few $1,000s, you can actually restore this patient in one visit and provide predictability for a long time until they're ready for the next stage. A lot of these cases are more than 10 years of age, and I'll show them. And these patients are happy to come in and show their cases to all my college students. They can see and assess all the patients I see in the program on my webinar. So I'm happy to come in and let you examine them, and you can see the results, so they're not different. Coming back to the same patient, Nimesh, was the fact that we have a really hard surface. And you can see the patient, Nimesh, is putting the same stresses as she did on the anterior teeth. And so there's a pushing forward, and there's no give. So Christy was able to see fremitus on these areas, and we've been continually adjusting these areas for the patient every 12 months. Patient come back, specially effects, so I'll sit down and refine these margins. Again, you can see some wear. This is over the 4-year period, some wear here, and wear is stabilized. Now, there's a continuous eruption of the teeth. You can see the passive eruption of the bottom teeth. And the patient's quite happy to live as the teeth. I don't see any problems. If I see really major issues, I will go ahead and reconstruct. But at the moment, she's maintaining very well. We do need a sacrificial arch when you have a zirconia on top. Unfortunately, it's the teeth in the case. But when you think about it, this teeth have been maintained quite well. So again, every 12 months we go back in and refine, readjust, okay, maintain like good, anterior guidance for seed exclusion, and have an even contact. Sometimes I can add some composites here. Okay, we should wear with time, that's fine. Wear is a natural part of it. Okay, so the way you test fremitus, you place the articulate paper, press on the tooth, and pull. That gives you a contact pattern. Okay, Now, we do have beautiful results in zirconia, there's no question. You can also have the same results in metal ceramic, so that's not an issue. You just need to have a good technician how to do this. Again, in many ways, you don't get your higher green carbide burr, green diamond burr. Don't even do that. If you try to do it with a green ball burr, you will fracture, you have a crack propagation. You have a phase change in the zirconia surface, then you have a crack propagation. So use a silicone type of burrs to adjust and shape and refine your occlusion. And in this particular case, I have very, very minimal contact. I can pull through. You can see the little dots here. That is just on the lateral, okay? And canine stops will remain as with the implants all the way to canine, have a minimal contact. Only when a strong clenching, hard clenching, I'll have a contact on the anteriors. So this is 10 years post-op. I believe we've maintained quite a good aesthetic integration. Sure, the lower anteriors need to look at, but she's quite happy. So this is where I will probably stop the lecture. And if you have any questions about the college, I'm most happy to answer any question you might have. So give you back.
Dr. Sarkis, somebody, Dr. Mohammed asked, have you supplemented with splint?
With a patient?
Yes.
That's a very good question. If Christy is on board, does she have a splint, Christy, or she doesn't wear a splint? Can you tell me?
I don't think Christy's.
Is she here or is she not?
She's here, but I guess she's on mute.
Okay, all right. She can actually write. Okay, I think I have given the occlusion splint, but can I tell you the occlusion splint wearing is very, very, sometimes not quite as well as one should. So the question, Mohammed, is a very good question, is that you should...
There's no splint. Dr. Christie has replied. There's no splint.
That's right. You have to plan your restorations on the fact that patient will not be wearing a splint. So if you plan your restoration and rely on the patient wearing occlusion splint, and if they don't, how are you going to deal with the failure of your restoration? But most importantly, failure of the underlying supporting tube. So therefore, from that point of view, there's a special occlusion prescription, which I prescribe, and it's done in a way so certain factors, when I do wear and we create a natural way, that's why I bring the patient every 6 months and we check for parameters, make sure that the patient has got a natural wear. And unfortunately, with zirconia, you don't have that natural wear. So you really have to do extra service, extra maintenance to be able to provide a natural wear so you reduce the load. And that's really important part of the treatment plan. That's why I always favor metal ceramic crowns with good gold backing, because gold has a give and other restorations don't.
Dr. Sarkis, may I ask a question?
Go ahead, Hamza.
Dr. Sarkis, what other material apart from zirconia could you use for anterior?
I would use
in this patient.
In this particular case, I was metal ceramic. So that was absolute metal ceramic with a good 1 mm gold mark just to grab the root. There's no question about it.
Yeah, much appreciated.
No question about it. Thank you. And I'll be especially the high gold noble alloys. And those crowns are not cheap. They're about $650. And they, besides being high gold, we also gold plate them. They use a nice yellow effect, and it gives you beautiful aesthetics, very warm color.
There's another question. What was the TMG status pre and post-op?
Can you say that again? I'm so sorry.
What was the TMJ status pre and post-operative?
Was the question by? Okay, Mohammed. Okay.
Yeah.
Mohammed, thank you for your question. May I ask you a question? Do you feel that temporomandibular dysfunction is caused by an occlusion?
Yeah, I believe so. And there are studies, and of course, there are different school of thoughts. Yeah, I mean, you may have your own understanding, but I just tried to understand that did it make any difference from this extensive case?
Okay. Okay. I'm looking at 2011 here for you. Okay. I'm looking at temporomandibular joints here. What do you see the joints? What do you think of the joints? Can you say anything on the joint? No? Mohammed, are you there?
No, I'm trying to understand. This is 2020 you mentioned?
Yeah, this is 2011. This is 10 years ago.
Oh, sorry, 2011. Well, I mean, I can see some changes on the right mandible, but
I'm going to keep going, and
Yep.
I'm going to take X-rays. That's 2015. Okay. There's a joint remodeling. Okay, that's called adaptation. Sorry.
Oh,
Okay, it's remodeling. Can you speak up, please? So, would you tell your patient? The question is, you think she has TMD? I can tell you she has no TMD.
oh, that's good. That's what I wanted to know. That with the loss of vertical dimension and loss of posteriority, quite often, I mean, it's in my experience as well. I'm not talking about the papers and these things. So I have noted in a couple of patients. That's why I mean I wanted to correlate with your case. In the case which you have done, which is quite extensive, and it's good to know that the outcome is pretty good. I mean, as you said, I mean, it's remodeling.
It's remodeling. Well, let me ask you a question. What would happen with joint in remodel? See, gynecologists think that the joint is made of a steel, so your occlusion has to be perfect. Is it always so?
Not in my experience, though.
Okay. How many imperfect occlusions do you see that
Dr.
don't?
Sarkis, we have another from Khan Ravi, yeah.
Okay, Khan, the question is, I would ask the patient, say, here's the issue. I can see some bone adaptation on the lower left 6. Can you see that? There's a bit of a bone there, okay? Now, is this a periodontitis? My oral health therapist, Chris, will say no, gums are in a perfect position, okay? Is it loading? Well, we don't really know. I will refine the occlusion. Okay, now if I find that I'm losing more bone for any reason, then I will say, well, looking on the right side, they have the implants, maybe it's loading, but on the other hand, you look at the middle implant, there's a bit of a bone adaptation around here. There's no bleeding here, it's bone adaptation. This bone can go up and down, we don't really know. Because it's not a tooth, right? This is an artificial device. Implants are an artificial device. You put in the bone, okay? And the bone doesn't like implants. Bone hates them. You realize that? Now that's a paradigm change, isn't it? Why do you think, what's an osseointegration? Can someone talk to me about it?
Yeah, in a nutshell, look, I just missed half of the lecture, so
what did you do? You had to eat something, didn't you? Huh?
No, I was just driving from work to home. No, I couldn't miss it for the life of me. So I just happened to catch up with the TMJ question that Dr. Mahmoud asked.
So
you
what
asked
is
the osseointegration? So it's just the bone trying to seal off the implant, I think, in a nutshell.
Okay. Any other answers? Yeah.
Yes. Dr. Sarkis, can I add an answer, please?
Yes.
Well, basically what happens is, like, some part of the bone after the implant placement get onto the surface of the implant. That depends on obviously what surfaces the implants got. And then the bone remodeling starts from that point, plus on the other side, like it just starts from the alveolar side and plus on the bone residual on the implant.
Right. Okay, let me ask you a question. Anybody else? Isidora, you've done Dr. Brenner's course. You should know all about implants. So what's osseointegration?
no.
Izzy, are you there, Izzy?
Yes, sir. Yes.
Okay, well, you've done Dr. Brenner's course, so tell me about integration.
was a little while ago, but
I'm sorry. I'm putting you on the spot. Go on.
I assume it's like any other bone healing. Osseointegration is just the body filling the hole after an extraction or after damage. And it happens to be implanted.
Okay. So, can I ask you a question? How many place implants? How many of you? Huh? So you all place implants, right? Just about. So let me tell you, so far your view of osseointegration is incorrect, but somehow it works. So give me another integration. What happens is titanium inert? Is it bioinert?
No,
Okay,
it's not inert.
it's not inert. Then what is it? Is it bioactive?
No. I know you're gonna ask the second and third and fourth questions. I'll stop there.
No, it's okay. But I want to make you think. You see, you gotta think. What is osseointegration? What happens when you put something in the body? What happens? What's the reaction called? When you get a what do you call it? When you get a little sliver of the blood in your skin, what do you call? What happens there? What's it called? You get inflammation. Sean, you go raise your Sean. Go ahead. Huh? No one?
Someone sending a.
I'm so sorry. I just didn't want to disrupt Sarkis, but he was explaining very accurately about the healing process. So you said about the finger getting poked at. So I just dropped my raised hand. I'll let you continue.
Dr. Sarkis, Sean has sent us an entire link on osteointegration. And Naveed has replied saying it's a foreign body.
Foreign body reaction.
Yeah,
It's
a foreign body reaction. I'm sorry.
Reaction. That's right. So the question is why sometimes it fails, and most of the time it's stable. So you need to think about that. I'm not going to answer this question because I don't like answering questions. I like to make you think. This college is how to make you think. You see, and so far you can realize that sometimes you have to think outside the square and really ask the question why sometimes things work, why they don't work. If they don't work, what is your contingency planning? What happens plan B if things do fail? Have you discussed that with the patient? Does the patient know that things can fail? They may pay all this money to you, but things can fail. You see, as a clinicians, we all have to understand that we are dealing with biology, and biology is chaos. Why biology is chaos? Because in biology, 1 + 1 is never equal to 2. Aesthetics is chaos. So you're trying to have a controlled chaos situation. So we all have our important views, and we live by them, and we believe. We have a belief system, and I agree with that. And sometimes we look at that, we improve our belief system. I agree with that. And perhaps if you have a really strong belief concept, you should go to church every now and then. That helps, that helps you reinforce your belief system. But science is so cruel, so cruel. I tell you, it's so cruel. And we are clinical scientists. We deal every day with science. We try to experiment on our patients, really, in many ways. But I can tell you one thing: implants are foreign bodies that we place inside a bone, and there's a number of things to try to do to make it work. So think in terms of not a recipe. In this college, we teach you, okay, it's not a recipe. We teach you how to think. That's critical. So this is the issue. You can do 1 or 2 day courses here and there. There's no one going to connect you. There's no mentor on board to connect you. And this is what we have. We have really great mentors who can actually put things together. You start thinking differently. Here's lectures. See, when you ask me, oh, you're going to do this, it's a recipe. I don't want to know about it. Okay? But what's your result? You're going to play for results. Recipe.
My goal tagal sa Olympics.
I'm sorry?
My goal. Adoma ka naman Pilipina.
Go ahead. I can't hear you. Can you write for me, please? Any questions you have?
Yes, Dr. Sarkis, can I ask a question?
Go ahead, please.
The lower anteriors,
Right.
if you end up coming to that stage, you want to do something,
Yes.
what would be that?
Ah, good question. How would you do it? Dr.
Well,
Howard, Dora, start talking. I want you to come on board. Anyone does orthodontics? Here's a hint.
I'm here.
Okay, what would you do? Let me bring the case up. Let me bring the case up. I thought you guys would like it anyway. It's good to think. You see now, Dr. Patel, Nimesh Patel, you are thinking outside the square now, right? You're starting to think, right. You see, part of the protocol, I had to have my contingency planning that when this wear does occur, what do I do? And the patient knows about it. So what would you do, Dr. Howard? Your call.
Lower veneers.
How would you do lower veneers?
Well, they're very thick. And
Yeah,
that's part of the problem, how it's
okay.
How it occludes.
What would you do? I'll give you a hint. Give you a hint. You have.
Is it orthodontic?
Yes, I think so. Because you got your occlusion plane here, right?
Just extrude them.
Well,
intrude them a little bit.
Intrude
because
them.
it's all.
You would intrude them, wouldn't you? See, I would intrude them. So I'll have a prepless veneer almost. See?
Okay.
That makes sense? If you intrude them,
because now you got the anchorage, isn't it?
Oh, you got plenty of anchorage. Bond it here. You can bond the porcelain. You can use tats.
Why don't you just open up everything a little bit?
Yeah, but you don't want to replace his restoration. It's up to you. I would just drop it. No problem.
Why didn't you make them longer before?
Because it was comfortable at the time, you know.
Okay.
It was financial issues, other issues. So you can easily, anytime you can lower this. And then you add some composite if you want, and then you can replace it with porcelain. I would have composite here. That's my sacrificial arch. I wouldn't put any porcelain here. I'll put composite here.
Yeah, that's a great thing because I got exactly the same patient.
That's what it is. You see now, you see Nimesh, you start thinking. There's no recipe here. Okay? Because you need wear. Human beings need wear. When you put artificial stuff in their mouth, things won't function. But unfortunately, none of the lectures ever talk to you about this. If you go 2 or 3 day lectures, they'll tell you how great the work is. The trouble is, what happens after 1 year, 3 years, 3 years, 10 years? What happens? But you see real cases. You see real patients who come in and say, it's been 10 years. Look at the results, the effects, the problems encountered. That's real dentistry.
Yeah, I've been maintaining one patient 15 years, and I've been probably just waiting for that answer. If someday I have to do something, what that would be, you know, because the teeth are worn down. You don't want to cut them. You don't want to put crowns.
Many ways. Yeah. I was doing today. I had a major reconstructive case, and they're all onlay veneers with minimal intervention. They work. And we'll talk about that in nothing module 12, full mouth rehabilitation. Very common. But the important fact is that if we discuss the case, that's when this student brings 5 cases on board, and we teach you on the first module how to take photos, how to put your PowerPoint format, you know, the case history, describing the history. You start putting things in format, then you start thinking about the right way to gather information, the diagnostics, how to present questions, and you understand that, well, that's a part of the recipe of diagnostic formation. Okay, diagnostic information and integration. And then you think about treatment planning. Yes.
Someone's got a question, Kelvin Lin.
Yes.
At what stage would you do the intrusion? Question. When the wear reaches the pulp and becomes symptomatic?
Yeah. I don't think wear is going to reach the pulp, I can assure you. Okay. Because I'll continuously adjust the thick upper crowns, zirconia crowns, okay? So question is, what's an average wear of a tooth? Does anyone know what's the yearly wear of the tooth? Huh?
0.1 millimeter.
How many?
0.1.
I would go up to about 30 microns. It weighs. Okay. With a brush, it weighs more. Okay. And gold wears the best. This zirconia is fantastic, you know, but I haven't had that clinical experience because it actually does wear out the teeth. That's why when you do zirconia, you have to make it like a mirror. You got to make the teach you all that, teach you how to polish things. That's really important.
May I ask a question?
Of course.
The buccal edge of the lower teeth is very sharp. That seems to be what's striking on the upper front 4 teeth. Is it possible to kind of roll that edge so it's not actually occluding in a sharp way on the back of the upper?
You can, or you can do the opposite as well. This is probably anterior. This is probably more anterior guidance I'm assessing here.
Yes.
But I would be more inclined to adjust the upper, because if you adjust the lower, you go to create more passive eruption for the lower, so you don't want that.
Okay, but you want to roll that front edge so it's not
I would
catching.
polish, yeah, I would polish. I would.
So Dr.
Because you
Sarkis,
should have the
also.
you should
Oh,
have
sorry, Christian.
the height. I'm sorry. You should have
No,
the
you go ahead.
height. You should have the height remaining the same, but change the shape because you've worn them down. They're so thick through. You know, instead of being a nice incisal edge, it's a flat plane, quite wide, with a sharp edge.
This is 10 years. This is 10 years. Okay, this is 10 years. What she started with. That's what I'm trying to tell you. It's 10 years. I'm maintaining this patient for 10 years. And she has the option. It's her option. But if I have to pull a plug, I will pull a plug. No question.
So, Dr. Sarkis, if we're rethinking this case going 10 years back and we do the upper crowns with metal ceramic, would you have the ceramic on the palatal side in the occlusion area, or would you have a metal there?
Can you say that question again? I'll put Ryan hang in there. I'm going to answer your question there.
Yeah, so if we reconsider the upper crowns going back 10 years and we put the metal ceramic there, and you got the porcelain with the nice fuse with the gold, would you have the metal part in an occlusion with the
metal
all
day long? All day long, less wear, no question about it.
Okay, yeah,
no question. Now I'm going to ask Ryan. You asked the question. I'm just going to bring your question up again. Question is: did the patient have adequate bone upper posterior bone support to housing implant? They could not afford. What would the contingency? That's a good question. Okay, that's a very good question. The only, honestly, in that particular instance, you'll consider a precision type of partial denture, upper partial denture that you have the splintered upper anteriors, and you have a distal attachment, some type of sticker or different remote attachments, and which you will have no clasp, but you will design your restoration of a really good palatal support so that patient feels firm they can eat. It has to be removable. There's no other option. Now, there's not enough bone. If you said if finance was the option, that's the only other way of doing it, because we really need to improve here the smile on aesthetics. On a lower arch, we'll have a problem because you need to consider lower arch a lower partial, and that will be required same way. But when you think about it, when you add the cost of this and that and that, we look at precision attachments, partial dentures, it does add up a bit. So other than that, I would probably replace the existing crowns. This is a simple partial denture as well with good support, both upper and lower teeth, and chances are she probably won't wear the lower partial, but she'll definitely wear the upper partial. Now, if she could afford, there's not enough bone, then you consider the maxillary sinus, internal sinus leads, and the mandible. If she had no bone in the mandible, that would be very, very complex. Then, if she really wants fixed solution, there's always bone, just the distal the canines. So you can angle your implants and carry to the teeth. Then you got a shorter dental arch. That was satisfactory as well.
Dr. Sarkis, we have another question from Dr. Christina. Does the gold flow and the porcelain not? Question. Is that why go with the gold?
Gold is a bead. And
okay.
Bead.
Okay.
Ryan, have I answered your question?
Yes, thank you so much.
It's my pleasure. Thank you for your question. Any other questions about the college or about this case?
Sarkis, I've got a question.
Yeah.
Could I ask a question without you asking a question? So those lower front four teeth, if we wanted to restore them, I just think to myself, if you've got upper zirc, could we put lower zirc like for like where better longevity?
You're gonna cut the crap out of this
You must be joking, right?
teeth. You're gonna cut the crap out of this teeth. Okay, how much resistance tape? How much resistance foam do you have in there? For God's sake, you got very, very little resistance foam. You cut those teeth, you reduce their lifespan. I wouldn't do it. I would basically redo orthodontics, intrude them. You can easily intrude them straight up and down here, and then do your non-invasive post-on or composites. I'll do composites. I don't want to do post-on.
And
you
just
need a
ensure
sacrificial arch. You need a sacrificial arch. You need something to weigh.
and just ensure that you've got that mirror finish on the opposing.
Absolutely. Absolutely.
And I think from what you've said, if you have a mirror finish, it's almost natural wear.
Yeah, just still will wear. So it's just hard. See, it won't wear. It doesn't wear. You get a fremitus. You get a fremitus of the upper anteriors. Somebody's going to give. You understand? I mean, I don't want fremitus. I don't have a wear there fremitus. Fremitus is just no good. Fremitus is the first sign of you're going to lose his tooth. I'm telling you. You get lower the zirconia. Easy. I have placed thousands and thousands of zirconia. I've got a problem. Yes, I need to I have to adjust those occlusions. This is a daily routine in my practice. It's a daily routine. That's why when you do the course, you get a chance to visit the practice and see how it's working. Just like when you do the orthodontic course with Derek, you get to see how it's working. You have to understand it. It's very important. We treat a lot of complex cases all the time. All the time.
Thank you.
My pleasure.
Dr. Sarkis, we have one more question.
Sure.
Why not retract the lower teeth if you're going to do ortho?
Retract?
Yeah, why not retract the lower teeth if you are going to do ortho?
So retract, you mean lingual?
Yeah, just maybe taking it lingually if you're planning to do the ortho eventually.
Well, you can. It's not an issue because when you intrude them, you probably bring them lingually anyway. You see, again, the question is like you're thinking very empirically. It's an empirical question. Don't worry about that. Okay. You just want to lower the level and create enough room. And it doesn't matter where, if you intrude them, the issue is no retraction because you have enough room to build what you want to do.
Okay.
To me, I understand what they're saying, but you know, like you get the orthodontist who want to move the teeth this way and make them perfect this way, that way. Forget. Life's too short, I can assure you. You have enough space, restore it. I hope it answers the question.
Yes, I guess we're done with the questions for tonight. Not any more yet.
Okay.
Thank you so much, Dr.
Thank you,
Sarkis.
guys. Thank you so much, Dr. Sarkis. As always, a pleasure.
Thank you, Shweta.
Oh, thank you so much.
I actually agree. Shweta's doing a good commentary here. It's very good.
I feel like the cricket match. India versus Australia, is it? Bye.
I'm just going to pop through the details of our email address if anyone has any questions about the college.
Yes, I think Natasha and is the best person to speak to.
Yeah, and you can just email and someone will get back to you.
Yes, please. Thank you, guys.
Thank you all. You're most welcome to ask the questions. You have my details. Happy to help.
I'm just gonna leave behind our details here. So if anyone's got any questions, they can
feel free to just contact us at any point in time.
The one question is there?
No, that's just me.
Natasha's just sent across the email address and the phone number for the college.
And if you have any cases, you're most welcome to post it. I'm happy to help you all. Ravi, were you happy today with your answer or not?
Is Ravi online yet? Just let me have a look.
Yes, Saki. Sorry, I was.
No
I just muted myself. Sorry about that.
Always when you treat cases, think of the simplest way to do the case. Think the simplest way. Don't complicate your life. Sorry, don't complicate your patient's dentistry, their life, and naturally your life.
Thanks.
We're all done. I think everyone's got the details as well. So
Thank you all, and have a loveliest COVID day.
The lockdown.
never a lovely COVID.
Thank you, Doctor.
We're going to do our webinars weekly because of COVID. Yeah.
Can I have the day off tomorrow?
No, you can't have it.
You wish, Natasha, you wish.
Dr. Sarkis, Natasha's making me work tomorrow as well at 8 o'clock in the morning. I'm coming.
Listen,
So-
Natasha, I'll bring some coffee across.
Yeah.
Okay, we'll fatten you up. All right, we'll cross off for sure.
All right, I'll see you tomorrow.
You all, everyone, thank you very much.
Thank you so much, Dr. Sarkis.
Thank you, doctor.
Thank you.
Thank you.
Bye-bye. Good night. Thank you, guys.
Good night.
Bye-bye.
Good night.
Good night.